Hello and welcome to the Point of Care podcast. Today's episode is on the inpatient management of diabetic foot wounds. For some background, diabetic foot ulcers affect 15 to 25% of patients with diabetes over their lifetime. 50% of patients with diabetic foot ulcers have PAD, which impairs wound healing and increases amputation risk. More than 50% of diabetic ulcers become infected. 20% of diabetic foot infections lead to some type of amputation. Diabetic foot ulcers lead to over 1 million amputations annually. The 5-year mortality after an amputation for a diabetic foot ulcer is over 70%. Prior foot ulcers are the greatest risk factor for recurrence, with 58% recurrence at 3 years and 65% at 5 years. The most important other risk factors for the development of foot ulcers include poor glucose control, peripheral arterial disease or PAD, neuropathy, renal disease, smoking, the presence of callus, and edema. For the pathophysiology, loss of protective sensation from peripheral neuropathy leads to repetitive and unnoticed traumas. Motor neuropathy leads to abnormal walking and pressure points on the feet. Ischemia from peripheral arterial disease impairs wound healing. The callus formation leads to eventual subcutaneous hemorrhages and then the formation of an ulcer. Hyperglycemia leads to the formation of advanced glycation end products or AGEs, which impair collagen formation, prevent migration of inflammatory cells to wounds, and cause microvascular damage. The then exposure of ulcers leads to risks of polymicrobial infections. For your admission checklist, for the ABCs, evaluate the patient for sepsis or shock. When you're triaging them, ensure they have adequate perfusion and no need for an urgent surgery. You can calculate a PEDIS score, which tells you the 6 months prediction of whether the patient will get an amputation or have mortality. For your chart check, look to see if the patient has a history of diabetes, what their last A1C was, and their regimen. Also look for complications including neuropathy, retinopathy, or nephropathy. Look for peripheral vascular disease, their renal function, whether they've had any prior ulcers and have needed INDs, amputations, if they have any prior wound cultures, and if they have antibiotic allergies. You absolutely cannot miss necrotizing fasciitis, which may be seen with rapid spread or gas, and gas gangrene, which is a much deeper infection. You also shouldn't miss osteomyelitis. You can't miss ischemia, which is the 6 Ps, including pain, pallor, pulselessness, paresthesias, paralysis, and poikilothermia. For your admission orders, make sure you get x-rays and consider whether or not you want an MRI if you're concerned for osteomyelitis. You should send cultures if there's obvious purulence, and consult to podiatry and vascular surgery to begin the workup. For your initial treatment to consider, decide whether or not you need IV antibiotics if there's evidence of systemic inflammation. Make sure you get the glucose under control, and consider your pain management. For your HPI intake, when it comes to the ulcer, note the duration, location, size, and whether there's purulence. For local symptoms, ask about pain, swelling, numbness, tingling, or burning. Ask also about systemic symptoms including fevers, chills, fatigue, and weight loss. Ask about prior ulcers, whether they've been hospitalized, had any surgeries, or amputations. If they have diabetes, ask about their current regimen, their adherence, recent fills, and whether or not they're checking their sugars at home and what the levels have been. Ask about their foot care, including whether they're checking for cuts and blisters, and ask about the use of footwear or insoles. Ask about the patient's current smoking status, whether they have been a former smoker, and how much they smoke. Things to note on the patient's exam is whether they're toxic appearing and in any distress, suggesting sepsis. For their extremity exam, look for edema, their pulses, both dorsal and pedal, Dopplers if you can't feel the pulse, check for cap refill, the skin temperature, the evidence of pallor, the presence of vibratory sensation, and any numbness with a monofilament test. When looking at the skin, assess the size of the ulcer, the apparent depth, whether there's surrounding erythema, if there's purulence or drainage, any foul odors, and the presence of crepitus or evidence of bone or tendons that are exposed. For your plan, For the workup, let's start with labs. CBC, ESR, CRP, and A1C can all be useful. Send cultures. Blood cultures if there's evidence of systemic illness or you're concerned for osteomyelitis or necrotizing fasciitis. And if they get any procedures, make sure you send wound cultures or bone biopsies from them. Get an X-ray of the joint and send an MRI if you're concerned for osteomyelitis. Consider bilateral ABIs if you're planning for a procedure or you have concern for underlying peripheral arterial disease. And again, consult podiatry for debridement and vascular surgery to consider possible revascularization surgery. For treatment, if you decide the patient needs antibiotics, start with empiric antibiotics and narrow based on the results of surgical cultures if needed. Keflex, amoxiclav, Bactrim, or Doxy for 1 to 2 weeks can be chosen for mild evidence of cellulitis or diabetic foot wounds. If it's a moderate or severe infection, you can do ceftriaxone, Flagyl, and add vancomycin if you have concern for MRSA or Pip/Tazo if you have concern for Pseudomonas. In general, osteomyelitis is usually treated for 6 weeks with vanc and ceftriaxone and cefepime empirically, but then narrowed based on the results of bone biopsy cultures. You'll often need debridement with a surgical consultant of all non-viable tissue. Incision and drainage will need to be done for any evidence of abscesses, and amputation might be considered as needed for infection or necrotic tissue. Pain control can be with Tylenol, oxycodone for post-op pain. You can choose gabapentin for neuropathic pain, and in general, it makes sense to avoid ibuprofen, especially in patients that have evidence of CKD. After debridement or any amputation procedures, it's very important to have pressure offloading, either with casting, wearing of a boot, or having a knee-high walker. Glucose control is also incredibly important, and in general, the goal A1C is less than 8% to promote healing. You can also consider a nutrition consult. Revascularization might be necessary before a procedure, and you should discuss this with podiatry and vascular surgery. After a procedure, it's important that the patient gets follow-up with podiatry in 2 to 4 weeks to assess for healing and any need for any closure. Also, the patient should be engaging in regular foot inspections for the development of new ulcers either on the same foot or the opposite foot. If you remember nothing else, care for diabetic foot wounds and ulcers requires a multidisciplinary team including a podiatry, vascular surgery, and wound care. You can't miss necrotizing fasciitis, gas gangrene, or osteomyelitis. Get a CT if you're concerned. Osteomyelitis should be diagnosed via MRI, and bone biopsies should guide antibiotic treatment. The treatment of diabetic foot wounds most commonly requires strict glucose control, antibiotics, and debridement of dead tissue. Most infected ulcers are polymicrobial with mixed bacterial flora. Concurrent ischemia with poor blood flow drives poor outcomes in wound healing. Revascularization may be needed prior to procedures intended to salvage the limb, and pressure offloading is crucial after procedures to allow for healing. Patients should undergo regular foot inspections, especially if they have reduced sensation secondary to neuropathy. For some pearls, the plantar surface of the metatarsal head is the most common location of diabetic foot ulcers. Other common locations include the toes and heels. These are the common pressure points and sites of repetitive trauma. Osteomyelitis should be inspected if there's exposure of bone or tendon. If you can probe to the bone on the exam, it's osteomyelitis by definition. MRI is 90% sensitive and 82% specific for osteomyelitis and has a very high negative predictive value. The likelihood ratio is 0.14 if the MRI is normal. X-rays are valuable because they can detect gas and the presence of bone changes, but MRI is most sensitive for osteomyelitis. ABIs are useful for peripheral arterial disease screening, and you're considered to have severe PAD if the ABI is less than 0.4. Erythrocyte sedimentation rate, or ESR, is a non-specific inflammatory marker that measures the rate at which RBCs sediment in blood, reported in millimeters per hour, which reflects the levels of plasma proteins like fibrinogen and immunoglobulins, which increase inflammation. It rises and falls slower than C-reactive protein, or CRP. CRP is a more specific inflammatory marker for acute inflammation. It's a protein produced in the liver in response to inflammation or infection and rises and falls quickly. The levels aren't impacted by plasma components, and so it's more useful for monitoring the response to treatments. An ESR greater than 70 has a likelihood ratio of 11 for the diagnosis of osteomyelitis. It's useful for distinguishing between osteomyelitis and neuroarthropathy. Persistently elevated ESR and CRP may indicate inadequate source control. If revascularization is not possible or unsuccessful, and/or the tissue is necrotic or gangrenous and poses a risk to the patient's life, amputation may be the only viable option for management. For trials and literature, we'll link off to the IWGDF and IDSA guidelines on diagnosis and treatment of diabetes-related foot infections. There's also excellent review articles, Diabetic Foot Ulcers and the Recurrence in the New England Journal of Medicine from 2017, and Diabetic Foot Ulcers, a Review from JAMA 2023. That's all for this episode. Check out pointofcaremedicine.com to see the templates we discussed, as well as the pearls, literature, and links to other resources.